Don't assume that you know the answer. You may think that you have all the answers after being in the industry 2 or 3 years. Keep on asking questions. Challenge yourself. Try to go back to fundamental principles. Just focusing on Canada. It's an evolving industry. I've learned a lot over the years, and it's definitely an industry that's growing year over year.
Welcome to the Leader's Edge podcast. I'm Zach Ewell, market analyst and podcast producer here at Leader's Edge. In this episode, we take you on the ground to the Council's Employee Benefits Leadership Forum, where I sit down with Massimo Nini, Senior VP of Consulting, Underwriting, and Actuarial for AGA Benefit Solutions. When it comes to the topic of employee benefits, we've focused heavily on the American perspective in the past. However, in this episode, Nini shares what trends are impacting the Canadian market and breaks down similarities and differences between the Canadian and American healthcare systems. Discussions of GLP-1s, shifting legislation, and the Montreal Expos are all on the docket for today's conversation. Give it a listen. Massimo, thank you so much for joining me.
Yeah, Zach, thanks so much for having me. Great to be here today.
Absolutely. So we'll get down to my first question. Tell us about your journey making your way into the insurance brokerage industry.
Yeah, this is an interesting question because like many individuals in the space, you don't grow up wanting to become an insurance advisor. I think the way I got into the industry is really through my actuarial studies. And maybe I could start there because it's, I've always liked numbers, always liked math. And the first time I heard about the actuarial, industry was in the mid-90s. I was a baseball fan. Montreal. I grew up in Montreal. And at the time, after the 94 strike, the Expos went on a major fire sale, right? They got rid of a bunch of players. And they started looking at how do they become competitive again and financially relevant. And one of the things they looked at was building a new stadium. So Claude Brochu, the president of the Expos at the time, it was 1997, did a press conference and released his plans for a new stadium and mentioned that he called upon actuaries to do a financial feasibility study of the stadium. And I said, what is an actuary? So I looked it up, and I was getting close to the time of applying for college programs, applied in pure applied sciences, and ultimately went into actuarial at the university level. Started my career in the defined benefit pension plan space. After a few years in the space, I realized that wasn't where I wanted to spend the rest of my career. Defined benefit plans were somewhat on the wind down in the early 2000s, and I decided to pivot in the group insurance space. I learned a lot about the group insurance market through the actuarial studies, specifically about the U.S. group insurance market, and I felt this would be a good career. And I haven't looked back since 2005, 2006 when I entered the group benefits industry.
From your perspective, in your view, what are some key differences that distinguish Canadian group benefits from American plans that people like me, Americans, may not know of?
It's a question where we could spend an hour talking about, but I think I'll start with the foundation, right? In Canada, there is a very extensive government-sponsored healthcare program. It's a universal program. When we think about the spend of healthcare in Canada, it's about $400 billion. Under 10% of that spend is related to private insurance. So fundamentally, when you think about private healthcare insurance and group benefits in Canada, it's a supplemental healthcare plan. Major medical, hospital visits, physician services are covered under a publicly sponsored program. So fundamentally, the fact that it's a supplementary plan, the spend is much lower. So, the focus of employers when it comes to group benefits in the US versus Canada, I would assume that in the US, considering that the spend, my understanding, it's over 20% of salary on average that's allocated to group benefits and healthcare. When you think about Canada, it's probably in the 4 to 7% of payroll that goes through group benefits. So the focus isn't as high, so that is fundamentally a big difference. When we get into healthcare specifically, due to the cost and the spend, there's much more consumerism that's built into U.S. plans. We think about private, preferred provider networks. Think about high deductible plans, right? There's a lot of focus on the plan member, the insured, being a better consumer. You think about Canada, that's not the case. We have very limited use of PPNs, preferred provider networks. It's focused in the areas of pharmacies and very specific medical expenses like vision care. The presence of high deductible plans, virtually inexistent. So again, we want to encourage plan members to be better consumers, but it's not a big ticket item. I'd say another huge difference is the fact that in the US, it's very common to have an annual re-enrollment or an open enrollment period. In Canada, annual enrollments are limited to cafeteria plans, fully flexible plans. The average plan in Canada, there's no annual re-enrollment. So in essence, when you think about employees going in and adding dependents and things like that, it's done when there's a life event. When you think about voluntary benefits, it's a lot less prevalent in Canada, so there's less of a need to have an annual re-enrollment. So I'd say that's a big difference. And another big one, I think, is from a market segmentation. 2/3 of the market in Canada is allocated to 3 carriers. There's 10 carriers that dominate about 95% of the market. And virtually, when you think about the US, I know it is highly concentrated, the number of carriers, but I do believe that it's less concentrated compared to the Canadian market. So, there's a bunch of other things, Zach, but we'll leave it at that for the question.
No, that was broken down so eloquently. Like, yeah, that's interesting. So Health Canada just approved its first generic semaglutide, which is an active ingredient in Nova Nordic's Ozempic. Take us through Canada's journey with bringing GLP-1s to market. As I understand, it's been pretty rocky.
It has. Yeah, this is another big question. I'm actually presenting in a couple of weeks at a conference on the topics of GLP-1s, and it's around unlocking the value of GLP-1s. And yeah, it has been a rocky 4 or 5 years, when you think about Ozempics and GLP-1s in general. And it's not isolated to Canada. The reality is there was a lot of off-label use, in 2020, 2021, 2022. In Canada, all the carriers in and around 2022 or 2023 really tightened up their prior authorization processes specific to Ozempic. So, if an individual was using Ozempic strictly for weight management, they were no longer eligible if they didn't have type 2 diabetes. But when you think about the spend over the last 5 years, the cost allocated to GLP-1s, I think it's gone 6 or 7 times in the span of 5 years. When you look at the spend that's allocated to diabetes and obesity in Canada, if you look at 2021, I think the metric was roughly 8% of drug spend was allocated to diabetes and obesity. Fast forward to today, we're closer to 14%. So you think about the drug industry in Canada, the spend at large across all drugs was low to mid single digits in terms of annual increases. Diabetes and obesity have gone through the roof in terms of the increase. So, it's been a bit of a rocky situation, but with the approval of Wegovy, which is the weight management version of Ozempic, that has also taken off in the last few years in terms of the allocation. I think the stat is roughly 0.5% of drug spend in Canada in 2021 was related to obesity. Fast forward to Q1 of 2026, it's roughly 2.6%. So again, it's been an increase in the spend. And you've heard about Canada being the first country to approve a generic version of Ozempic, obviously. And in essence, Health Canada approved 2 drugs in the last few weeks. We are, a lot of plan sponsors out there, and also plan members and Canadians that are not covered under private insurance plans are anxiously awaiting, the rollout of generic Ozempic in pharmacies. What I'm hearing from a cost perspective, the brand name version of Ozempic is currently $5,000 to $8,000 per year Canadian. The generic version should be anywhere from $1,500 to $2,500 per year. So it's a massive reduction. So, this is going to be very beneficial for plan sponsors. They'll see a reduction in cost because Ozempic is the largest drug right now from a spend perspective in 2026 in Canadian plans. So there'll definitely be some relief. Wegovy will also be released eventually as a generic version. The first phase of the release is for Ozempic. Health Canada has not yet approved the generic version of Wegovy, but we talk to clients all the time. We talk to plan members at times, and this has been a very polarizing topic. the use of Ozempic and weight management in general. When we think about weight management in Canada, roughly 40% of plans offer obesity management. There's still a number of plans out there that do not cover obesity drugs. I have conversations with plan sponsors around their view on obesity and the potential impact that the generic version of Wegovy will have on their decision. And there are some plan sponsors out there that will reconsider their position on obesity management as a result of this reduced cost that we're expected to see once Wegovy is released as a generic version.
That's fascinating. A lot of the similar conversations, just the use of GLP-1s here and just the emergence and taking over the market and everything. It's everywhere,
It is. And it's a topic where, I talk to reinsurers as well in terms of trying to get some data around what the impact will be on pricing, be it on critical illness rates, life insurance rates, disability rates, and ultimately on healthcare expenses. No one has a good answer. And oftentimes it's a 15 or 20-year projection in terms of when we're going to start seeing the benefit. And we talk to the carriers all the time. Realistically, they're not tracking the metrics currently that would enable them to incorporate the beneficial impact of obesity management on their rates, be it for life insurance or disability. But I strongly believe that there is an ROI, and it's one of those where I have conversations with plan sponsors to understand their benefits philosophy and making them see both sides of the fence, because it is an investment, it is an expense, but ultimately, we believe that there will be, huge benefits to offering these drugs.
Moving on, as I understand it, the province of Alberta has recently passed a healthcare bill that has the power to significantly impact the private insurance market there. Being a Canadian benefits broker, could you tell us what the key changes could be?
This is a big one, and I know a lot of people in Canada, various provinces are anxious about what this means. Because Alberta's Bill 11, there's a few different components. There's three key components. The first component is the ability for physicians to practice both on the private insurance side or the private delivery model, and also under the public system. So right now in Canada, you have to, as a physician, select one of the two streams. And most physicians practice under the public healthcare system. So there's a bit of a concern around, us creating a two-tier system in Canada. I know for the US, this is, it's one of those where the private insurance market dominates healthcare delivery. In Canada, it's not the case. And there's a lot of individuals in Canada feel strongly about our current system. And, the Canada Health Act has 5 key guiding principles when it comes to healthcare delivery. And in essence, the federal government has this framework with the Canada Health Act, and the various provinces then manage their own government program. But in essence, there's a few key principles, but 2 of those principles are universality. So basically, every Canadian should have access to basic medical services, and there shouldn't be a financial barrier to access healthcare. And the other one is public administration. By and large, 90% of our costs are administered publicly. And in essence, there's virtually very few medical expenses that are covered under the public healthcare program that could be an eligible private insurance spend. So for example, if there was a carrier out there that wanted to insure major surgeries or physician services, that would be illegal under the Canada Health Act. So the vast majority of these services that are delivered under the government healthcare program are not eligible for private insurance. With this system being rolled out or projected to be rolled out in Alberta, there's a lot of discussion around what does this two-tier system mean, and will this lead to private services being eligible for private insurance? So it's a big discussion. If we think about it more from a practical standpoint, there's two additional key measures that are being introduced that have a direct impact on plan sponsors. One is the fact that right now there are various publicly sponsored drug programs in Alberta, one being the post age 65. So it's a seniors program in essence. And individuals over age 65, in essence, that program becomes the first payer. So if you're actively employed and you have access to a private group insurance program, the public program at age 65 kicks in and becomes the first payer. And the private program is the second payer. That is the current model. With the changes being proposed by Bill 11 in Alberta, they are flipping the order, and the government program will be the payer of last resort. So in essence, there could be a massive financial impact on plans. And this also extends to the pre-65 plan. So all Albertans have access to a public program. There is a premium that's required. There's no underwriting, so everyone is eligible. And there are a number of Albertans that are covered under the public program and also under a group program. And again, with Bill 11, the roles are inverted. If you are eligible to a private program, that will be the first payer. So in essence, we're having discussions with clients in Alberta around plan design, introducing annual maximums, formulary management. A lot of employers have already implemented these tools, but it's important for them to understand the ramifications of Bill 11. The third impact is actually the inability for plan sponsors to implement an age 65 termination age on healthcare or to reduce healthcare benefits at age 65 for individuals that are actively employed. And again, most plans do not have an age 65 termination age, but this really crystallizes the fact that you can no longer do this. So we're having discussions with clients around, contractual wording and making sure there's no discrimination and that they will remain on side with Bill 11.
I'm wondering, is it also the thought that, all the other provinces are like, if it's happening in Alberta, then it could happen.
There's 10 provinces in Canada, 3 territories. Oftentimes when one province implements some major changes, the other provinces are looking, and our 2 largest provinces are Ontario and Quebec. Over 50% of the Canadian population are in those 2 provinces. And there is a worry, absolutely, in terms of what does this mean for the other provinces? And will there be an additional shifting to, the private insurance model? What does this mean for plan members? So there's definitely some concern in that area.
And my last question, do you have any advice for young people that are looking to break into employee benefits and insurance as a whole?
Yeah. If you would have asked me this question 5 years ago, probably would have been a little bit different than today. Post-COVID, in the AI era, a lot has changed, and in Canada, when you look at the insurance industry and the employee benefits advisory industry, most organizations have not returned to a 4 or 5 day in-office work week. There's still a lot of remote work. When I was growing up in the industry, I was in the office every day, overhearing conversations, being able to nudge a colleague, go over to a cubicle, go over to see someone more senior, have a conversation. And not to say that it's not possible to do that remotely, but it is different. So I do feel that I encourage individuals that are starting off in the industry to really connect in person. Going into the office at times could be, time consuming, but I do encourage that. And I think it will have a positive impact on your career. And I do think that AI is another huge disruptor over the last few years. There's a lot of answers that are readily available. I think it's affecting people's, analytical skills and thought process, and I encourage our team at AGA to really challenge themselves, and absolutely let's leverage the tools, but let's have some critical thinking here and some good discussion up and above the tools that are available. And ultimately it's about asking really effective questions. Don't assume that you know the answer. You may think that you have all the answers after being in the industry 2 or 3 years. Keep on asking questions. Challenge yourself. Try to go back to fundamental principles. And in essence, it's a great industry. The employee benefits industry is so great. We talked about a few items and things that are changing in the industry, just focusing on Canada. It's an evolving industry. I've learned a lot over the years. And it's definitely an industry that's growing year over year. And I think it's an excellent way to build a career for anybody considering, a career in the employee benefits or as an insurance advisor.
That was my conversation with Massimo Nini of AGA Benefit Solutions. I hope you enjoyed it. For more podcasts, please subscribe wherever you listen or go to leadersedge.com.